to a normal pace now. So let's get started. Good morning, everyone, and welcome to a special seminar from the HIV Center, specifically being hosted and sponsored by the Clinical Translation Corps of the HIV Center for Clinical Behavioral Studies. I just want to welcome everyone here today. Thank you for being here. This is a very interesting and special seminar, and I will be letting Dr. Susan Tross, who's one of the two directors of the Clinical Translation Corps, do the introductions. I will remind everyone that we do have a HIV Center Grand Rounds this coming Thursday, and it will be with Aaron Siegler from Emory University, and it's Department of Epidemiology, and his topic is bringing HIV prevention to scale with innovation, key directions, and future steps. So that's this Thursday, November 7th at 9:30, our usual time for Grand Rounds. And that will be a virtual webinar like this one. And so good to see everyone. Hope everyone has voted or will vote sometime today. And with that said, I'm going to turn it over to Susan Tross. Go ahead, Susan.
Good morning, everyone. Sending you messages of hope for today. And, the HIV Center has given us, the Clinical Translation Corps, a fabulous opportunity to assemble people who are dedicated and expert in the care, treatment, and service delivery with people who are living with HIV, affected by HIV, at risk for HIV. And this brings us to our speaker today, Reuben Robbins, who you know as an associate professor of clinical medical psychology and psychiatry, and both a clinical and a neuropsychologist. He has contributed to many, many research projects examining neurocognitive functioning, mental health, sex and drug risk behaviors, and adherence to treatments. And his research is domestic. It is in South Africa, Thailand, Uganda, and I'm probably not even getting all of it. As a PI on many research projects and actively, I just want to emphasize the work developing an easy-to-use, highly automated tablet application to quickly assess neuropsych functioning and screen for neurocognitive impairment. And you're going to hear all about that in just one moment. The way that we choose Clinical Translation Corps presenters is by popular demand. And absolutely everyone in our Corps and everyone they could think of really feels that Reuben's work speaks to a crucial aspect of functioning and patient experience, which affects everything else. So, Reuben, thanks for taking the time from all this productivity to talk to us today.
Well, thank you for the wonderful introduction, Susan. I have a lot to live up to now in this talk, so let's see how it goes. So, today, the title of my talk is Novel, Equitable, and Fair Approaches to Assessing Cognition in People Living with HIV. And I think I'm going to actually talk about the equitable and fair parts first, or unfair parts, and then get into the more novelty. So, and I guess since this is the webinar format, we'll hold questions to the end. Let's see now if I can get things to work here. All right, let me go here. So I don't have any disclosures other than that I am a creator of the NeuroScreen app, which you'll learn about in a few minutes. So let's talk a little bit about the brain, why this is important. So the central nervous system is susceptible to many types of insults. And I'll talk about viral infections of the hour, HIV, in just a moment. But our brains and central nervous systems experience insults from all kinds of things: tumors, substance abuse, mental health problems, stroke, neurodegenerative diseases. And that affects tens of millions of people a year globally. And all of these insults will affect our cognitive abilities or neurocognitive abilities. I may use those words interchangeably today. So HIV, as many of you know, also affects the brain. HIV has an affinity for the brain. It can cross the blood-brain barrier, unlike other viral infections. And early in infection, it enters the central nervous system, and there it replicates and affects neurons via immune and inflammatory responses. And those effects can damage neurons and interfere with optimal brain functioning. And that leads to cognitive problems. In research, in the HIV research, there's a nosology for cognitive impairment that's called HAND, or HIV-associated neurocognitive disorders. And HAND ranges from the most severe form, HIV-associated dementia, to mild and asymptomatic types. So there's a variety of studies out there, and as many as 50% of people living with HIV have some form of HAND, and usually that's mild and asymptomatic. And that's among people who are on ART and virally suppressed. HIV-associated dementia, which is the most severe form of HAND, is much rarer these days than in the earlier days of the epidemic, so pre-ART or early ART. And in terms of HIV-associated dementia mostly affects people who are not on ART or who are diagnosed with advanced AIDS conditions. And having cognitive impairment, whether it's mild or severe, can interfere with your activities of daily living, like medication adherence, achieving developmental milestones. That's for younger people living with HIV, graduating college, maintaining employment. It affects the quality of life and even decision-making. So, when we talk about cognitive abilities, we typically talk about, as a neuropsychologist, we think about things often in these domains, learning, memory. So learning is the encoding of new information, and memory is the retrieval of that information. Working memory is the ability to hold smaller pieces of information in our minds for a short period of time, like hearing a phone number and then being able to jot it down on a piece of paper. Not that we do that anymore, actually. Attention is the ability to attend to what's in front of you. Executive functioning is a really popular ability now. It's actually a lot of different things, and working memory is probably a part of executive functioning, but that's like our control center, the CEO of our brains. It's planning, organization, response inhibition. So there's a lot of different components to executive functioning. Processing speed, how quickly we're thinking and putting together information, and motor ability, particularly like dexterity, strength, and fine motor dexterity. So that's typically the types of skills and abilities that will be affected when there's cognitive impairments going on. So there aren't ready estimates of global rates of cognitive impairment or HAND. Just, studies out there that suggest around 50%, although it differs. And the 50% number I'm citing comes from a sort of old study now, but it was one of the largest in the United States, the Charter study. Some people might know of it, multi-site, and they found the 50% rate. Globally, there are about 39.9 million people living with HIV. That's all adults and children. And if you estimate around 50% or even lower than that, a quarter of people have some kind of cognitive problems, that's just a lot of people globally. And we have to think about, well, how do we address that? How do we deal with that? Because it's a lot of people. And it's also really important to note, a lot of my talk actually will focus on low and middle income countries, because most of the people in the world living with HIV come from low and middle income countries, where there's just a different level of access to cognitive testing and cognitive tests. And we'll talk some about that. Now, actually, in our own country, there are access issues to cognitive testing as well, particularly for resource limited places. So while most while most people living with HIV are adults, it is important to note that there are still about 1.7 million children under 14 who are living with HIV. And that actually talks about the need for adult and child tests. So it's also important to really highlight the diversity of people living with HIV, which is really important in the context of cognitive tests, as I'll get into it in a few more slides, looking at the issues of diversity. So here in the United States, we know that HIV disproportionately affects people of color and sexual and gender minorities. So that, we have to think about any kind of intervention to have sensitivity around those particular issues. Another really important issue is older people. So in the United States, about half of the people living with HIV are now 50 years and over. And that's thought to will increase over the years as, with better ART and more access to it, people will live longer. And globally, about 25% of the global population of people with HIV are 50 years and over again, and that'll also really increase as more people get onto ART and the regimens that are available globally get better. So older people with HIV have higher rates of comorbidities than age-matched older adults, including cognitive impairment. So that's what's important. And another bit about that is that just as we grow older with or without HIV or other problems, we naturally begin to experience some level of cognitive decline. Much of it is normal, but what's not really clear is that for people with HIV, are they experiencing cognitive problems? Is the decline faster? There's definitely higher rates of it, but the normal aging process coupled with the burden of HIV may place different demands and a different burden of cognitive problems in older people with HIV. Now, similarly, among the younger people in the world living with HIV, children, many of them are now actually the kids who were born with HIV. Many of them are now young adults, and we consistently see cognitive issues in people living with perinatal HIV. But we don't really know how lifelong HIV acquired prior to all these key developmental phases or during those key developmental phases, as well as the type and duration of ART affect those cognitive outcomes later in life. So, here I'm just painting a picture of why it's really important that we have some kind of tool and an accurate tool to assess cognitive functioning, particularly in these different populations and globally in low and middle income countries. So here, among the young people, it's important to note that millions of children are living with HIV and in perinatal HIV, actually, this is just getting at the same thing that I just said, this is from the slide from Africa, showing the proportion of different age groups and where they're located and the density of people living with HIV and who are young, older, and middle age. Oh, sorry, let's talk about what these cognitive tests are. We'll begin to get into some of the fairness issues and equitability issues. So cognitive tests are the cornerstone tool to measure cognitive functions for the diagnosis and functional assessment of many psychiatric and neurological conditions, including in HIV, and they can inform treatment planning. So we know with the millions of people living with HIV, there's a great need to have tests that can do this in these populations. Now, also, cognitive tests are the cornerstone tool to understand brain behavior relationships for research, to understand what are the causes of cognitive problems or in what are the causes, what are the modifiers, mediators, etc. So cognitive tests, and many of you already know, they're non-invasive performance-based tests, subjective tests of brain functioning. Traditionally, they're done on paper and pencil forms and other apparatuses. like the pegboard. You can see the slide moving. They're increasingly, though, becoming computerized. Traditionally, they're bulky with numerous stimulus books and the need for stopwatches, pens, pencils, etc. Brain imaging is also a cornerstone tool to understand how the structures in the brain are affected. And they can show areas of damage, but where they really differ from cognitive tests is MRIs and CT scans. They don't show the functional impairment. So it's not possible. You can observe the damage in imaging, but it doesn't show you what those cognitive effects are or what the cognitive problems are. So you might see white matter hypointensities or lesions in certain areas, but you don't know if that's actually causing a memory problem or an attention problem. Now, once you get those tests, you can correlate them, but on their own, they don't show the extent of what the cognitive issue is. Is it memory? Is it attention? Is it language? Is it all of the above? So in terms of cognitive tests, it's really important to point out that most of these tests were developed in weird countries, and that's weird as in Western, educated, industrialized, rich, and democratic. So resource-limited settings and low and middle-income countries often lack tests developed and normed for their populations and languages, as well as they lack the personnel needed to administer, score, and interpret the tests. Yet they bear the greatest burden of HIV. And just a small point here is that here in the US, cognitive tests are a highly regulated test. So like in the state of New York, you have to be a licensed psychologist to actually administer and interpret these tests. Yeah. That's different in low and middle income countries, but there's a gateway to even accessing these tests. And if you want to buy them from some of these test publishing companies, you have to prove that you're qualified to do so. And you have to, be qualified in your state to do it with your license. So, and here we are, the tests, they assess, they're these objective assessments of all these different abilities and skills that we talked about: learning, memory, working memory, attention, executive functioning, processing speed. And we measure each of those different abilities. So cognitive tests must have evidence-based validity to be used confidently. So they have to be valid, and there's lots of different types of validity. There's face validity, content validity, construct validity. That's your psychometric validation with correlations. The tests need to be correlated to other tests assessing the same thing. You can do receiver operating characteristic curves to show the sensitivity and specificity of the test to detect a specific outcome, whether that's cognitive impairment or dementia. You can do factor analysis to look at the factor structure of your tests. There's criterion validity, which would be, I suppose, similar to a ROC curve, and cross-cultural validity. There's developmental validity. There's a lot of different types of validities. And that's really important, that tests have evidence that they are valid in different contexts and with different populations. So it's really important also for cognitive tests to be understandable, which would be, I think, a form of face and content validity, as well as acceptable and usable to the people taking the tests. So understandable and acceptable, right? That means here that examinees, they need to be able to understand the instructions and task demands. And that requires appropriate and understandable language in a person's native language. And as we'll see soon, there's a lot of languages in the world. And weird countries, there's really just a few. There's English, French, Spanish, but the world has a lot more languages than that. The stimuli, so you can see the picture is flashing on the screen. The stimuli need to be relevant to the examinee. So if you're going to show pictures of objects of animals and ask what they are, which is a very popular form of testing, the population needs to actually know what those images are. And I have a little example coming up. So And the examinees need to understand, there needs to be an understanding of the acceptability and usability of the test interface for different populations. So if it's a computerized test, well, does the population have familiarity with using computers or tablets or touch screens? Or if it's paper and pencils, can your examinees use pencils? That might be an issue out in the bush in Africa somewhere. So administration issues, traditional paper and pencil cognitive tests require rigorous training to administer, score, and interpret these tests. Usually you get a PhD like myself to be able to do all that. There's complex skip patterns, there's basal starting points and all that stuff that you need to know about to reliably administer these. And you need appropriate norms for our tests. Those are needed really to make clinical interpretations. And for research purposes, sometimes you don't need those if you're just looking at correlations or mechanisms. But if you want to make a clinical interpretation, you really need the norms. So norming is complex for cognitive tests because education, quality of education can greatly impact performance on the tests. And most commercially available tests are normed on sex and age. Some include education. And most commercially available tests have norms from weird countries like the United States or Europe, which don't reflect populations in low and middle income countries. And I'll have some examples of some of the issues around that. So I know this is a webinar, so and I didn't prepare one of those poll things, but what animal is this? I'll give everyone just a few seconds to think about that. So I'm pretty sure everyone on the webinar knows, or maybe I don't know who's on the webinar, but I'm assuming if they're from the United States, they know that's a beaver. And actually, this is a common item, and there's the famous Boston naming test to test for aphasia or language. Also, there's for children there's the Peabody picture vocabulary test. You're looking at pictures of things and saying what they are. So is this, if you didn't grow up in a place that had beavers, this may not be an appropriate test item. So what's this animal? Does anyone here know? Now, it's interesting. This is the Saola from Vietnam. It's a type of bovine animal. And I didn't know what that was, but people from Vietnam may know what that is. So my point here is that the stimuli of the test actually have to be relevant to the people taking the test. And to show a beaver to someone in Africa where there are no beavers may be problematic. And it might not be a sign of a cognitive problem if they can't name it. Similarly, if you show someone here a picture of a saola, we may not know what it is. And we may say, oh, that looks like an antelope. Well, that's like calling a beaver a rodent. So you're close, but not quite from the perspective of a cognitive test. We want to see how the brain is working to call up the specific name for that animal. So there are a lot of important issues that I'm sort of highlighting here about biases in our tools. So I'll take a quick tangent to talk about biases and how they relate to some other tools to cognitive tests. So one of those came out during the COVID pandemic, and that showed how some of the systemic biases in our tools were affecting diagnosis and referral for certain people to get oxygen. So during COVID, we saw that the pulse oximeters that were being used to assess the oxygen level in your blood, which would help you get a respirator or not. So it turns out that these pulse oximeters were calibrated on people with light or white skin and are now known to incorrectly estimate oxygen levels in people with dark skin. And that was a bias we found that led to many Black people not getting the care that they needed. So it wasn't giving an accurate measure. So because of it was not calibrated or normed on diverse people. So it's not just pulse oximeters, though. Research has shown that forehead thermometers also do not work as well in people with Black people, right? So we have these great tools, but they're not calibrated for the diversity of our populations, of our people. Similarly, kidney disease diagnostics are also known to underestimate illness in Black patients. Right, creatinine tends to run higher in Black people and is a key component of this eGFR formula used to diagnose kidney disease. And to adjust for higher creatinine levels in Black people, a race correction was used. And in order to qualify for kidney transplant, your eGFR score had to be low enough to be considered end-stage kidney disease, but because Black people's scores were bumped up for this correction factor, they often had to wait longer until their kidney disease reaches a later, more severe stage. So I guess most likely a benign effort to make this quote unquote fair led to the eGFR scores not being fair for many people. And cognitive tests have also suffered from that similar kind of bias. In the last few years, a lot's come out with the NFL, the football players, right? They have higher rates of dementia than the general population because of the hits to the head, and cognitive tests are used to diagnose dementia. And it was identified a few years ago that how the cognitive tests were used to diagnose concussions in NFL players were biased. So that Black players had a harder time getting a dementia diagnosis than white players. And that was due to a similar race correction as those kidney tests. So it was easier for white players to get the diagnosis than Black players, and Black players were then denied access to services and payouts to help them deal with this really serious problem. So unchecked bias in our measurement tool leads to serious consequences: misdiagnosis, missed opportunity for treatment, and poor outcomes. So these race corrections actually are like really also can minimize or overlook a really important fact about race. Race is not a unidimensional construct, right? It's not a race. Most people we know are actually multiracial, and most race corrections do not address multi-ethnic or multiracial individuals. So this is critically important because HIV mostly affects people of color and people from vulnerable, under-resourced communities who often face many layers of systemic or structural and individual bias. So this is the case for the HIV epidemic here and globally. So we need to make sure our tools and our treatments actually accurately address the issues of our very diverse patient populations. So I want to highlight now some of the issues I uncovered in my work in South Africa. So when I was a postdoc here, actually at the HIV Center, and that'll sort of set the stage for the novelty. I'm talking more here about equity and fairness of these tests or lack thereof. So actually when I was a postdoc here and I was visiting South Africa for the first or second time or something, I got to sat in on a cognitive testing session with a child in a fetal alcohol syndrome study. And one of the tests they gave was the children's memory test. That's a common test given here. But this particular test is you have to listen to a story and then you have to repeat it back. And one of the stories is about Native Americans and bison. And that's what they were having this kid do in South Africa. And I sat there just stunned, thinking, this is not very relevant. And I thought it was odd because these kids are not learning about US American history. So that led me to do some research around those issues. And, anecdotally, I asked my colleague, I said, how come you're reading this test? Well, that's what they had, and how do they do on this test? And they said, oh, overall, the performance on these tests is not very good. And, because it's not really, nobody does well on them. So for many settings, especially those in low and middle income countries, cognitive tests are usually imported from the West or from our weird countries. And and then adapted. And sometimes, and I'll say adapted with air quotes there, because sometimes adapted simply means that they are just translated into a language. And all adaptations are not equal. And I'll get more into that later. So one of the first studies I did, I think I was still a postdoc then, is we wanted to look at using the Montreal Cognitive Assessment, which is a really popular cognitive test everywhere these days, and see if it could detect HIV-related problems in adults with HIV in South Africa. And so we administered the MOCA to 39 HIV positive and 39 demographically matched HIV negative South African adults. Mean age was about 29 years old, with a mean of 11 years of education, and about 2/3 of the sample is female, which was reflecting the HIV epidemic. So we administered the MOCA, and while HIV positive participants performed worse on average than the HIV negative participants, there were some really important caveats. There were a lot of ceiling effects across numerous items on the test. For example, most participants could not draw the cube correctly. So that's one of the first items you encounter there, is to draw a cube. But you can see here, these are sample cubes. They couldn't draw cubes. Now, does that mean that they have a cognitive problem? Most also couldn't correctly identify the picture of the rhinoceros. So here's again this thing where you show the pictures, what animal is this? And it turns out actually that all three of these animals, the lion, the rhino, and the camel, are indigenous to the African continent. And going into it, we thought maybe the camel would be harder to identify because that's a North African thing and we're in Southern Africa. So the camel's not indigenous to Southern Africa, but it was actually the rhinoceros. Though we did notice people were referring to it as other pachyderms like a hippo, things like that. Also, you have to do the serial 7. So if anyone knows what that is, count backwards from 100 by 7s. Most people had a very hard time doing that, although they would just revert to doing it by 10s. So we saw these kinds of ceiling effects across these different items. While you did see an overall performance difference in HIV positive and negative, we saw a lot of people, regardless of HIV status, performing poorly on specific items on that test. So, and that actually, we saw a lot of people, the HIV negative, these are HIV negative people around 29, 30 years old on average, they're performing more similarly to the older North American adults with Alzheimer's disease from the normative sample of the MOCA. So these are the normative sample from the MOCA of Alzheimer's patients. They're over 60 and they're from North America. And you can see, if you look at the yellow highlights, the cube drawing, the naming test, the digit span test, the serial 7s, and the abstraction test, that people perform more similarly to people with Alzheimer's disease from North America. Now, these people did not have Alzheimer's disease. And then the orientation one, people performed more like they had mild cognitive impairment. These are HIV negative adults who you interact with them and they don't have dementia, and you know that. They have jobs and things like that. Oh. So that led us to want to do some more in-depth understanding of what is the experience. Have they taken these tests before? What does this mean to them? Which is something nobody, there are very few, I shouldn't say no, but this is a very researched areas, qualitative assessment of what it's like to even take these tests for people who've never done them before. So to understand this more, we conducted some semi-structured interviews with 22 participants, 15 with HIV, 7 without HIV, of similar ages and gender, who recently completed a battery of cognitive tests. So it could have been the MOCA, or there was another research study going on where they got a full neuropsych battery. So we found that all 22 reported that they had never done any tests like this. And when asked about their overall experience taking the cognitive tests, we had responses such as this. It's difficult to do something accurately when it's your first time doing it. Therefore, it would be better if you show me or lead me. When asked about specific tests, such as the ones that require drawing, like the cube drawing, we had responses like this. Well, drawing is something I was unable to do. I hardly ever do that. I never even draw. And and among the time tests, where participants are told to stop when the time is up, people reported that experience is that it makes me think it must be stupid not to finish the task within the time limit, even though you're not expected to. So these are important elements to understand what that experience is like. So one, they're not even drawing. So if you can't draw a cube, just means you might not have ever done it before. And in fact, these are South Africans who, this was back in the 2010, 12, this is a little while ago. And these are people in their 30s, late 20s, early 30s. So these are people who grew up during apartheid, meaning they got the access to the worst education. They may not have even had all the resources. So likely did they have opportunities to draw? What kinds of resources did they have in their schools? So this is just very important to highlight that coming into the standardized testing format is very different for many people. And to take these performance-based tests, many people haven't ever done it before. So it really highlights, some of the issues that we face, that we have to think about with our cognitive tests in these settings. And how do we begin to get at that and understand the validity of our tests? And just a total side note, very briefly, the one where the person thinks they're stupid because they're not finishing the test in time. I begin to wonder, and other people may wonder, well, is that something similar to stereotype threat? We know there's lots of research that stereotype threat can impact people's performance on standardized tests, where if you go into it thinking, oh, I'm not as good as other people because of my race or some other factor, you may actually do worse. So if you're in the middle of a test and all of a sudden you feel like you're stupid, is that going to then subtly affect your performance? Maybe it's not going to affect your performance to make you look demented or have Alzheimer's or something, but it may actually affect your performance where you're not doing as well as you could be. It's not an optimal environment to highlight your actual abilities. So another important thing to think about is the mental health workforce, especially globally, right? We don't have globally, it's even questionable here. Here it's more of an access issue perhaps, but it's having the experts around to administer these tests. They're not exactly the easiest test to administer. In many settings, especially in low and middle income countries, community health workers or lay counselors are used throughout the care cascade to address these shortages, the human resource shortages. We were wondering, well, could we see if lay counselors or community health workers could reliably administer some of these cognitive tests? So we had them do the International HIV Dementia Scale, which is really easy, very quick. You have the person do the, I forget, there's 3 words you have to remember. You repeat them and then you recall them later. Hat, I forget the 3 words there. But one of the tests in there is fist edge palm. So that's a motor programming test. Now that's a popular neurology test. And that's, you have your fist, edge, palm. You just have to do that sequence over and over again. And it's actually really hard to administer correctly. And we found that when our lay counselors gave the International HIV Dementia Scale, 80% of the participants screened positive for dementia. But what turned out is that most of that hinged on that motor programming task. So they had a really hard time accurately determining if somebody was impaired on that. Because if anybody's ever done that, if anyone is in the audience has ever given that test, it's actually challenging to do. So it's also really important to note here that, like, in terms of the access to mental health workforce, you can see here's the per 100,000 population, right? In the United States, we have 29. I think this might be psychologists, but around the world, we have far fewer people. And Norway actually is doing even better than us. So finally, on this note, we also wanted to understand from actual HIV providers in South Africa what their knowledge and practices, screening practices, and training needs are for HIV-associated neurocognitive disorders. So we did a email-based survey to hit mailing lists of people, known HIV providers in public and private sectors. 105 surveys were completed among 45 MDs or doctors, physicians, 52 nurses, and 8 academics, all who provide HIV care. We found that half of the providers reported encountering HIV infected patients on a weekly basis, about 21% on a monthly basis, and then less than a third only encountered HIV patients a few times a year. 73% reported that all users of their clinical services are offered HIV testing. 17 reported that they had HIV patients who expressed concerns about their neurocognitive problems. And again, this is in South Africa. Only 12 of those providers reported doing any screening for cognitive problems. And they used tests like the orientation to person, place, and time, and the mini mental state exam, which are really used to, their screening tools used really for dementia. So fewer than 5 had really ever used the Montreal Cognitive Assessment and the HIV Dementia Scale. The point here is that few people on the ground are doing any screening for this. The participants did report on limiting factors for that. Most people, 74%, reported like they just didn't have the training or expertise to do it. They didn't even know, most people didn't know what screening tools were really available for this or which ones were the best for this. Many, of course, just lacked the time. And they wanted actually more training to do this. And most people, you can see in table 3 there, most of the providers thought it was important to screen for this. They were actually concerned about people having hand and the implications for that. Most actually would recommend it for patients and as well as employers. And most said they would be likely to screen for hand if these limiting factors were removed. So this just shows that among HIV providers in South Africa, there's a real interest in screening, but a lack of expertise and a lack of available tools that people are knowledgeable about. So now we get into the novelty. So this is where this NeuroScreen app came about. There's an app for that. So to address these gaps, we thought, well, could we have a smartphone or a tablet app that could make testing really, really easy, maybe even faster? So NeuroScreen is a tablet-based app. It's an Android OS app. It's highly automated. It's easy to administer by non-experts. Training in its use doesn't take long, a couple hours. It has the current core battery and validated battery. There's 12 brief tests. It takes about 25 minutes to get through all of it. It assesses learning, memory, processing speed, motor speed, working memory, executive functioning. It has audio, video instructions, which are really good for low literacy populations. It works on and offline. Data are synced to a server. And we've done a great deal to try to reduce the bias and make the test understandable and acceptable to populations all over the world. Let's see. These are just some screenshots of what it looks like. So currently, there are 2 tests that require an examiner or an administrator to have the tablet, like the word, we have this word list learning. So the examinee hears the words, and then the examiner has the examinee repeat the words back, and the examiner has to tap on the screen which words they said. Then there's a number span test or digit span like test. Similarly, they hear the span of words, and then they have to repeat it back, and the examiner has to enter them into the tablet. But the rest of the tests are more self-administrable, although we don't totally do a self-administration because we always have someone there to monitor what's going on to see if there's any problems or the person has any questions. So let me talk a little bit about our adaptation process. So it is very rigorous. And the first part is the translation. So we translate it. We do a rigorous translation process. Actually, we've come up with what we call a group consensus method, where we have a forward translation done by somebody who's bilingual English, actually not necessarily English. I'll talk about that a little bit later, but they translate it, do a forward translation. Then we have multiple 3 to 4 people who then do a back translation from the target language back into English or whatever the primary language was. We go through that. They're blinded to what the translations are. And then we identify any issues where there are discrepancies in the back translations, and then meet and talk about whatever the issues are and come up with a consensus on what the best approach is. Excuse me for 1 second. So actually, to help facilitate that, we've built a web app that facilitates the blinded translations and allows the back translators to view the video instruction tasks without audio to give them a context for what they're doing. Actually, we're learning that for some languages, machine translation or AI translation can be helpful. It's less useful for smaller language groups, and AI actually can help identify highly discrepant translations, at least from the back translations in English. Once we have a final set, we have to make the audio recordings and then sync the audio recordings with the videos. And another sort of novelty is we found that AI voices have actually been pretty good for some languages like Swahili, Malay, Mandarin, and Tamil. Now, they're not perfect. You have to go in sometimes and edit them, but it's a way to have low cost, pretty accurate voices that you can rapidly produce. So to address the potential biases in our tests, we have developed a cognitive interviewing, actually with a colleague at Einstein. Actually, I think Dana is a member of one of the cores. Anyway, to address these issues that could stem from culturally inappropriate stimuli or poor translations or acceptability and usability issues with the tablets, we go through this rigorous cognitive interviewing process. This is a sample of like a video from one. So we've developed this adaptive cognitive interviewing protocol for evaluating the acceptability, understandability, and usability of the cognitive tests. In our protocol, we present participants with the test from the app. We have them take the test and then ask them a series of questions or probes about their experience taking the test, such as, did the instructions make sense to you? How did you decide to do X and Y? Were the stimuli acceptable to you? How is using the tablet to complete the tests? When participants make errors during a test, we might stop them and ask them about what happened to better understand it. If they didn't understand the instructions or what was it that wasn't clear. In our protocols, we videotape participants' interactions on the tablet, as well as ask follow-up questions about their understanding using laminates of the tests. And this guides how we develop new tests and make modifications for certain aspects of the tests that don't work well. And we're currently writing up this protocol and hope that it can push the field to develop more understandable, acceptable, and less biased cognitive tests. And there are, it's important to note there are guidelines out there for test development and adaptation through the International Test Commission and APA. But usually, for the most part, their guidelines focus on survey type questions. So questions about feeling states or recalling what happened in the past or specific symptoms. And they don't actually address the unique aspects of these performance-based tests that have visual and tactile stimuli. So that's why we've come up with this modified cognitive interviewing process to address those particular issues. And we've done that in South Africa with adolescents and older adults. In Uganda, we're doing it now in Malaysia with adults. Sorry. We've also made it a point to assess the participants' experience with technology. And despite many participants, especially those in South Africa and in Uganda, that have never used a tablet before, we find that most find completing their neurotests easy to very easy, especially for younger participants. On the slide here, on the left side, we have, these are adults from New York and South Africa, and you can see that adults in New York, the question, ever used a computer, smartphone, or tablet? Vast majority of people have all used these devices. You compare that to South Africa, and you're looking at a much smaller number of people who've used tablets and computers, but most have used smartphones. In terms of ownership, most people from the US own a smartphone, a computer, or a tablet, much less so in South Africa, although most people do own a smartphone. And then we asked people to rate, how easy or not they found NeuroScreen, and most people in both places find it easy. Sorry, the thing is blocking my screen there. The easiest test to complete in both settings was finger tapping. The most difficult, actually, I guess, in New York was also finger tapping, but trail making in South Africa. On the right side, these are adolescents, so mean age of about 15 from Cape Town and Kampala. And if you look at the percent who owned any of these things, much higher in the youth, actually much higher in the youth than the adults from South Africa, but much considerably higher than in Kampala, except for the smartphone. And comfort using a computer or smartphone, you see that they report much higher comfort in South Africa in the adolescents than in Kampala. But across both settings, most participants find using NeuroScreen to be easy to very easy. And they both find the finger tapping test to be the easiest. And the most difficult, they didn't identify a specific one in South Africa, but in Kampala, it was trail making. So you can see that even in populations that haven't used a tablet before, don't own one, they're reporting that NeuroScreen is acceptable and fairly easy to use. So today we've published numerous papers providing evidence for the psychometric validity of these tests that highlight the feasibility of adapting these cognitive tests to an mHealth format, that they can be used by lay counselors in South Africa to detect cognitive impairment when compared to an expert-administered multi-hour neuropsychological test battery with a sensitivity and specificity in the 80 to 90% range. It's culturally fair in South Africa. It has construct validity when compared to traditional paper tests in the US and in Thailand with adolescent and young adult populations. And giving its ease of use and shorter time requirements, as well as strong psychometric validity, we think it can help make neurocognitive testing and screening more accessible, as well as allow researchers not focused on the brain or neurocognition to include these measures in their studies. We also think it could make the generation of normative data much more feasible in these settings. And it was actually recommended as a screening tool for people with HIV by the UNAIDS in their 2022 Integration of Mental Health and HIV Interventions Key Considerations publication that came out. So to date, we've actually adapted NeuroScreen for a variety of languages throughout the world. This slide really highlights the need for many different languages because there's many countries like South Africa where you have very multilingual people. And while certain places like South Africa and Uganda, many people speak English, they may not be totally fluent in it, and they may have an indigenous language that that's the language they use mostly. So in Uganda, we've adapted it to Luganda, which is like the national language, Lusoga, Luo or Acholi. We're developing a Runyankore version. In Kenya, we have Swahili and a Duluo version. We've been working right now in Malaysia to have a Bahasa Malay version, a Mandarin and Tamil version there, Malagasy and French for Madagascar. We have Wolof in French for Senegal, French for Ivory Coast. In South Africa, we have a Xhosa, Zulu, and Afrikaans version. Many places actually have many different languages that they rely on, and having tests available to in those local languages can make testing more accessible and perhaps fair. So some of the novelty about NeuroScreen is, I've talked a lot about, I'll call it the front end, sort of the test, what you're interacting with, and the acceptability of that. There's also a lot of back-end innovations to NeuroScreen. We have the ability to generate customized individual reports immediately. Reports can be sent to specific people or synced with medical records via APIs. NeuroScreen actually collects thousands of variables. The analysis we've done to date have focused on like 12 primary scores, but we actually collect a variety of data for the TRAILS tests and the mazes tests. We have path data. We also know for anything where there's reaction times. For the TRAILS test, we know that the time between individual circles that you're connecting. For the other matching tests, we know how long you're spending on each item. So there's an opportunity there to use data science to perhaps do computer adaptive testing paradigms, or look at more subtle changes and differences. And use, if with path data, you could do some AI image analysis to look at those things. Here's an example of an individualized report with norms. This is a study where we did have some norms. You can immediately generate a report that shows you where the performance is, how the person is performing. You can customize that to have different language in there, and it can be sent to very specific people. So that's a really nice clinical feature that we would love to really begin to use. And future research, we want to adapt NeuroScreen for use with young children and older adults. We just submitted a private foundation grant to try to adapt a NeuroScreen for young children, like 2 to 5 in Kenya. We want to use NeuroScreen as a tool for neurocognition studies to understand, what are the sources of cognitive impairment in people living with HIV, medical, social, and environmental exposures. We have a grant that is just getting started in Uganda to do just that, and looking at the sources of cognitive problems in adolescents and young adults with perinatally acquired HIV and horizontally acquired HIV, as well as uninfected controls. We want to, examine implementation factors related to using NeuroScreen in clinical practice, which some of our colleagues in Malaysia have begun to do. We would love to develop norms for global populations. Some future things that I would like to do is, I think if we could integrate some voice recognition for the verbal learning and number span test. Then you could have someone administer the test who does not speak the same language as the person taking the test. And again, I mentioned these data science approaches to the incredible vast array of data that we do collect from the tests. So in conclusion, rigorous adaptation of cognitive tests can help make them more acceptable and understandable to global populations. Tablet-based tests may be viable for community health workers to deliver cognitive tests accurately and reliably. New methods and test formats can help make cognitive tests more acceptable and accurate for populations in need of them. And I just want to thank, all my collaborators around the world, here in New York and South Africa, Thailand, Malaysia, Uganda, that, without all the participants, we would be nowhere, and all of the colleagues and collaborators, we wouldn't have been able to accomplish this, as well as our funders at NIH who've given us lots of funding. So that is the end of my presentation.